Okay, ladies and gentlemen, welcome. In this last session of today, it is dedicated to unboxing the coronary microcirculation, a very timely issue, I would say. I'm here together with my co-chairman, Javier Escaned from Spain, and Javier, as an expert in the microcirculation, will also give the first lecture about INOCA, ANOCA, a step-by-step approach.
So, thank you very much, Nico. And I have actually planned my lecture as a sort of introduction for the following ones, because it's going to be a very interesting session. Now, this is the image that the ESC has proposed in the latest edition of the chronic coronary syndromes guidelines to depict what myocardial ischemia in chronic coronary syndromes is. And as you can see, it's an iceberg where the largest part of it, the underwater, corresponds to non-obstructive myocardial ischemia. Now, if you look to the structure of the heart, and this is a very nice reconstruction made by a good friend of me, Joseph Span. It is actually a frozen heart that has been sliced in multiple cuts, and each cut has been photographed and put together. And you can see, of course, that most of the coronary circulation is intramural. It is all the arterioles and capillaries that are inside the myocardium, while the vessels that you have on the surface, the epicardial vessels, constitute the minority of the intravascular volume. Now, in clinical practice, you'll agree that we concentrate to investigate mainly the epicardial vessels. This has been changing swiftly, but you know, for decades, the microcirculation, the largest part of the coronary circulation, has been ignored. And of course, what we should be looking for in patients who have chronic coronary syndrome. So first, of course, it's true that we should be looking for flow-limiting stenosis, but we should also be looking for structural changes in the microcirculation, like arterial thickening or decreased density capillaries, density of capillaries, or vasomotor disorders that may affect the epicardial vessels or the arterioles. Now, if you want to think in a stepwise approach for physiological assessment of chronic coronary syndromes in the cath lab, that is the main introduction of my lecture to what is coming, you may follow this scheme that we have followed in the 8-angio study. So basically is you use the pressure guide, you use the angiogram to find if you have 90% stenosis. I mean, that's for sure that they are going to be generating ischemia in most cases. If you have less than 90% stenosis, you interrogate with a pressure guide wire. And in case that the FFR or RFR or any of the physiological index is negative, or in case that you do not find any stenosis, then you assess the causes of non-obstructive ischemia using the acetylcholine test, measurement of coronary flow reserve, and resistance. Now, I can tell you that in the 8-angio study that included 350 patients, it took only 15 additional minutes to invasive angiography, and it was very safe. And if you use this, you find exactly what the ESC was putting in the iceberg picture. With angiography, you identified only a cause of ischemia in 32% of patients, of those that are referred to the cath lab for investigation. If you use the strategy I told you, you identify something abnormal that causes ischemia in 84% of them. It's an amazing increase in the diagnostic yield of an invasive procedure. And of course, again, like it was proposed in the ESC in the iceberg picture, INOCA, or ischemia of non-obstructive origin, is more prevalent even than obstructive coronary artery disease in patients sent to the cath lab with chronic coronary syndromes. Remember that in most cath labs in the world, these people are leaving the cath lab without a diagnosis. And now you have the possibility of making a diagnosis that is actionable, because you can see if it is a vasomotor disorder, endothelium-dependent pathway, or if it is a structural change in the microcirculation, endothelium-independent measurements with CFR and resistance, or if it is a mixed problem. Now, how you do this in the cath lab, I'm going to just show you an example. A patient that continues having angina after PCI, despite having this very nice two-stent technique performed 6 months before. So there's no restenosis, of course. We give 2 micrograms of acetylcholine over 40 seconds, no changes in the epicardial vessels. But when we reach 100, we have this non-reflow phenomenon, so to speak, a slow flow that you can see here, angina, the angina that the patient refers, and then, of course, EKG changes. And you give nitrates and all these results. So we have found something very important in this patient. Perhaps even PCI was not needed to treat angina. Then we proceed to see if there are any structural changes in the microcirculation by looking at coronary flow reserve and microcirculatory resistance. Now, coronary flow reserve is abnormal in this patient. We could discuss why is it normal, but certainly it's below 2.5. The value of 2.5, that is the one that uses a cutoff. Microcirculatory resistance is under 25, so we consider it okay. It's interesting that this phenomenon, you know, sometimes is combined with pre-existing abnormalities or normalities, because myocardial bridges is something that you consider normal. But before, we used to consider myocardial bridges as something that was causing obstructive ischemia. Now we know that in many occasions, these intramyocardial segments actually are associated with vasomotor disorders. And why is this important? It is important because if you perform stratified treatments according to what causes myocardial ischemia, you have many more chances of being successful in treating patient symptoms. So if you have a structural coronary microvascular dysfunction, that means any of the indexes that we are going to be discussing later that tells you that, like coronary flow reserve or myocardial resistance reserve, etc., then you know that the patient, you cannot change this structure of the vessels from one day to the other. You cannot increase the capillary density. What you can do to help the patient is to decrease oxygen consumption. And this is the first step, and of course to control also cardiovascular risk factors that may have been propitiated that. But if the patient has a vasomotor disorder, remember, very frequent cause of angina, then you have many chances of improving the symptoms of the patients, because calcium channel blockers plus statins plus ACE inhibitors are really effective in treating these symptoms. So if you're interested in this, you can access all the information that I have shared as a bibliography using this QR code. So thank you very much.
Thank you, Javier, for this nice introduction. We will have ample time for discussion at the end of the session.
Fantastic. And with this, actually, as I mentioned, we move now to a more in-depth analysis of how to measure the coronary microcirculation, particularly what it is a structural microcirculatory dysfunction. And Nico is going to share with us the importance of absolute coronary flow measurements and microcirculatory resistance reserve. Thank you very much, Nico.
Thank you, Mr. Chairman. Ladies and gentlemen, in the next few minutes, I will try to outline a new methodology for very precise measurement of absolute coronary blood flow in milliliter per minute and microvascular resistance reserve to assess the coronary microcirculation. The method is quite common in Europe at the moment, but little applied outside. Recently, the equipment has been approved in Korea, in Australia, and in Malaysia, and it will be soon approved in Japan. These are my disclosures. And the introduction about the coronary microcirculation has already been given by Javier. We know that ANOCA and INOCA is a frequent problem, and we also know that after PCI, sometimes, despite a good result, complaints persist, and that can also be due to either structural or functional microvascular disease. How do we have to assess the microvascular today? That's difficult. We have Doppler and we have Bode's thermal dilution, IMR, but both of them are rather inaccurate, especially operator dependent. They are non-specific, influenced by epicardial disease, and in a number of patients, these signals are not adequate. In the last years, a new and innovative and extremely precise method became available for measuring absolute blood flow and resistance at rest and at hyperemia based upon continuous thermal dilution. And more importantly, from those measurements, an index microvascular resistance reserve can be calculated, which is a kind of FFR for the microcirculation. Let me try to explain how it works. You see here a guiding catheter in the coronary artery. You see a wire, that is a regular pressure temperature wire from Abbott. The tip of the wire is in the distal coronary artery, and there is the temperature sensor. And then there is a small infusion catheter, 2.2 French, which is advanced in this case at the proximal part of the LAD. Suppose we are interested in the microvasculature of the anterior wall, then we put this catheter in the proximal part of the RAD. Then saline at room temperature is infused through that catheter. And due to the specific design of the catheter, the saline mixes very well with the bloodstream. And suppose now that the temperature at the spot where the saline is entering into the coronary artery is 3 degrees below blood temperature. And suppose that after complete mixing with the blood, the temperature is minus 0.5 centigrades below blood temperature. There's a factor 6 difference. That means that the bloodstream must equal 6 times the infusion stream, so 60 milliliter per minute. And in fact, you can give it in this equation, blood flow is saline flow multiplied by the ratio of the temperatures. And there is a correction factor 1.08, which accounts for the difference in specific heat of saline and blood. So that's indeed very simply, and it can be performed almost instantaneously together with an FFR measurement. Here you see an example. The screen is quite familiar to you. The red line is the aortic pressure and the green line is the distal coronary pressure. The hyperemia that is important is just induced by saline. If you give a saline infusion of 20 milliliter per minute, you will create hyperemia within seconds. With saline 10 milliliter per minute, you will have resting conditions. Here we start, there is a small gradient, but upon start of the saline, you see that immediately maximum hyperemia develops and your fractional flow reserve is 0.77. If you look at the temperatures, we have zeroed the temperature before we started. Then you see that during the infusion, the temperature goes down a little bit. The number is minus 0.34. Then the temperature sensor is pulled back quickly to the tip of the infusion catheter. And there, of course, the temperature goes down. It is minus 4 in this case. And then the infusion is stopped and everything goes back very nicely and quickly to normal. The FFR is 0.77. The maximum blood flow is easily calculated and is 252 milliliter per minute. And the resistance in the anterior wall is 325 Wood units, all normal values. So with this Corventis display screen, you have all the relevant parameters, the infusion rate, the mixing temperature, the infusion temperature, the flow values, the resistance values, and the FFR in one screen. This is the equipment you need. It is the regular pressure wire from Abbott, also measuring the temperature. It is the Corventis software, mostly available in the labs. And then you need a specific infusion catheter, it's called ray-flow catheter. And you need a pressure pump to infuse the saline. And of importance, this should be a high pressure pump, generating pressures up to 350 psi. That means that a normal pharmacological pump is not suitable, but for example, your power injector in the cath lab can do it. In conjunction with fractional flow reserve, all these measurements can be performed within 5 to 10 minutes. You just have to position the pressure temperature wire in the coronary artery like an FFR measurement. You advance that ray flow monorail catheter. That's very easy. You connect it to the saline pump. You measure the temperature in the distal coronary artery. And if you are satisfied with it, you pull back the pressure sensor and measure the infusion temperature. And as I said, with 10 milliliter per minute, you get resting conditions. With 20 milliliter saline per minute hyperemia, no need for pharmacological stimulus. Then one step further. You can understand that flow and resistance are territory dependent. The larger the territory, the larger the flow, and the lower the resistance. You would like to have a measure for the microvascular function which is independent of mass. And intuitively you feel that that must be something like a resting microvascular resistance divided by a minimal microvascular resistance at maximum flow. No resting microvascular resistance in itself is difficult because as soon as there is any epicardial disease, or as soon as the patient is excited, or as soon as there is a catheter in the artery, resting is not true resting anymore because it is counteracted by coronary autoregulation. So it is important to take resting resistance as it would be without anything disturbing the coronary artery. And it is not difficult to measure that. It is given by this equation, microvascular resistance reserve, which is the true resting resistance divided by the minimal resistance. And fortunately, this is very easily calculated by just dividing CFR and FFR and multiplying it by aortic pressure at rest divided by aortic pressure at hyperemia. And if you use that index, it is very precise. It is independent of mass, blood pressure, heart rate, and completely independent of any kind of epicardial disease. Here you see an example with 10 milliliter per minute rest, 20 milliliter per minute. All the values you measure are given here. Your FFR is 0.84. You can calculate absolute coronary flow reserve, 227 milliliter per minute hyperemic flow divided by 68 resting flow, and your MRR is 4.1. And that is what really characterizes the microcirculation. So I believe that this measurement is the holy grail of the coronary physiology. You can easily measure all the parameters. You do not need a hyperemic drug. You are measuring FFR automatically at the same time. For the first time in history, you can also measure absolute coronary flow reserve, and you can calculate this index microvascular resistance and express it in terms of CFR and FFR. So these three major indices are combined in what we call the principal law of coronary physiology. If you like to read it at your ease, you can look at this paper published a year ago in JECC by Marta Belmonte. It is a real kind of cookery book describing step-by-step the methodology. It was accompanied by an editorial von Feddertin Fuster, who said continuous thermal dilution should substituting Doppler flow and bolus thermal dilution for the assessment of the microcirculation. Thank you for your attention.
Thank you very much, Nico. Thank you, Professor Pijls. So we continue now with Dr. Ando, who is going to speak about coronary spasm revisited. So that is the other type of functional disorders that you can find as a cause of non-obstructive ischemia. Thank you very much, Dr. Ando.
Thank you. My talk is about spasm provocation testing. These are the latest Japanese and ESC guidelines. Both strongly recommend spasm provocation testing as a class 1 indications. However, despite these strong recommendations, this testing remains underutilized in real clinical practice. There are a few reasons for this gap. First, it takes time and feels bothersome. Second, safety concerns may stop doctors from doing testing. This slide shows a standard protocol of provocation testing provided by Japanese guidelines. As you can see, there are so many steps and feels time-consuming. But recent studies suggest that some steps can be safely omitted. And this study shows the incidence of complications such as cardiogenic shock or ventricular fibrillations according to the response to the initial 20 microgram dose of acetylcholine in LCA. As you can see, if the patient has minimum response to the 20 microgram dose, patient has no complications at the following 50 microgram dose and 100 microgram dose. This suggests that in such cases, 50 microgram dose can be skipped and directed to the 100 microgram dose. This is another study showing the positive rate of spasm testing in the RCA according to the response to the 100 microgram dose of acetylcholine in LCA. If the patient shows a minimum response to the 100 microgram dose, no patient has a positive response to the 20 microgram dose in RCA, and only 3% has a positive in the 50 microgram dose. So we can skip this 20 microgram dose and go directly to the 50 microgram dose. So this is a revised protocol from these findings. If the patient has a negative to the 20 microgram dose in LCA, we can skip the 50 microgram dose and go to the 100 microgram dose. Furthermore, 100 microgram dose is also negative. we can skip 20 microgram dose in RCA and go direct to the 50 microgram dose in RCA. This revised protocol has the potential to reduce the overall procedure time by around 50%. Another reason for the limited use is safety concerns. This study shows the incidence regarding to the procedures. The incidence of death was 0%, but the risk of ventricular tachycardia or fibrillation is not negligible. So to minimize the risk of complications, early detection of coronary spasm is essential. To achieve this, we perform the spasm provocation testing with a pressure wire inserted into the coronary arteries. This slide summarizes the advantages of using pressure wire during the spasm provocation testing. First, it allows continuous pressure monitoring. Second, pressure wire improves the catheter stability. And finally, continuous monitoring enables prompt decision-making. I'd like to share the illustrative case. This is a baseline angiography. And after the insertion of pressure wire, we initiate the acetylcholine injections. As you can see, the pressure monitor displays both aortic and coronary pressures. After the injection of acetylcholine, the aortic pressure signal was lost, but we can still identify the coronary pressures. After that, coronary pressure began to decrease, so we interrupted the acetylcholine injections and go to the coronary angiography. The time from the acetylcholine injection was about 30 seconds. Angiography shows total occluded LAD, and also circumflex was occluded. So this suggests a very critical multivessel spasm. We immediately injected the nitrate several times. As a result, coronary pressure increased like this. And the angiography shows dilated coronary arteries. So in this case, real-time monitoring with a pressure wire enabled early detection of spasm onset, allowing us to interrupt the acetylcholine injections and administer nitrate before any complication occurred. Finally, I'd like to share the important notes on interpreting spasm provocation testing. In this case, there was no significant difference during the spasm provocation testing. The patient experiences mild chest pain, but ECG shows no change. So we go to the next testing, microvascular function testing, using the bolus simulation method. We first use intravenous continuous ATP as a hyperemic agent. As you can see, the IMR was elevated to 35, indicating structural microvascular dysfunctions. Next, we used the intracoronary necroangiography as an alternative hyperemic agent. The result was changed dramatically. As you can see, CFR increased to 9.4, IMR decreased to 13. So in this case, initial provocation test likely caused a microvascular spasm, resulting in a high IMR during the ATP infusions. However, subsequent intracoronary necroangiography relieves the microvascular spasm, and IMR returned to normal. So we diagnosed this patient as a microvascular spasm and initiated vasodilators as a medical treatment. In summary, optimizing the spasm provocation protocol and using pressure wire monitoring improves safety, efficiency, and diagnostic value. Thank you very much for your attention.
The next lecture will be given by Jung-Min Ahn from Seoul, from Asan Medical Center, about indirect assessment of microvascular function by pressure wire.
Thank you. Thank you, Nico. Pijls. Coronary pressure reserve is not the official name. I just name it because with a very similar idea with the coronary flow reserve. So this is a typical coronary flow measurement. After hyperemic induction, we only remember the two numbers, resting PDPA and the final, the hyperemic PDPA FFR value. So FFR is 0.70, suggested this stenosis would benefit from the revascularization. But sometimes look at the intermediate stenosis, the resting PDPA is 0.92, final FFR is 0.70. This case is resting PDPA is 0.88, final FFR is 0.82. This is a very huge pressure drop. This is a very little pressure drop. So from 0.92, 0.70, 0.88, 0.82. Actually, this is a very similar concept of coronary flow reserve. So we can calculate the pressure reserve like this, 1 minus 0.7 divided by 1 minus 92. Pressure drop is uppercase is 3.75 times, low case is 0.5 times. So I'd like to evaluate what is the prognostic value of this kind of concept. So previously, Niels Johnson and me and Frederick Zimmermann published one paper about the pressure-bounded CFR. According to the very conventional flow dynamic law, based on the pressure measurement, we thought we can guess the CFR boundary. So based on our large registry data, we evaluated like this. The pressure finding is a cardiac test MITVR. FFR can evaluate show the different prognosis regarding cardiac test MITVR, but pressure-bounded CFR cannot differentiate the risk of cardiac test MITVR. But in the per region analysis, there is some hint that the cardiac test or MI is higher in low pressure-bounded CFR population. But this idea was wrong because we didn't consider the hydrostatic pressure. If we consider the comparison between the coronary pressure-derived CFR measurement and Doppler wire measurement, very heterogeneous. But if we consider the hydrostatic pressure, the correlation is getting better. But even though, without such kind of consideration, I'd like to evaluate the prognostic value of coronary pressure reserve. So this is the distribution of coronary pressure reserve. Median value was 2.7. So pressure drop, the resting pressure drop hyperemic pressure drop divided by resting pressure drop is the median value is 2.7 times bigger. So according to the epicardial stenosis by FFR, there is no change because according to the formula, the epicardial coronary artery disease was adjusted by the resting PDPA drop. So I think this value was little affected by the epicardial coronary artery stenosis. So to predict the mortality at 5 years is 2.357. So conventionally, coronary flow reserve was less than 2 is higher risk, but similarly, CPR less than 2 significantly increased the overall mortality. So according to the quartile, the lowest quartile, most highest mortality rate compared with the other. This is spline curve. The CPR, as CPR low, the hazard ratio of mortality is significantly increased. But target lesion failure regarding the progression of atherosclerosis was not associated with the CPR. And how about the FFR? FFR is not associated with the overall mortality, but associated with the target lesion failure. Every subgroup showed that the lower CPR is associated with the higher mortality. So let's go back to the typical pressure curve. We can guess, not accurate, but we can guess the patient CPR. So upper patient CPR is 3.75, final FFR is 0.70. Yes, this patient, this stenosis required the coronary revascularization, but overall mortality should be low. Low patient, final FFR is 0.82. Coronary revascularization is not necessary, but CPR is only 0.5. So coronary pressure reserve is very low. We guess that this patient may have a higher mortality in the future. Thank you for your attention.
Thank you very much, Dr. Ahn. And then we have the presentation by Niels Johnson about no-stenosis angina, mechanisms explained by cardiac PET. Thank you very much, Niels.
All right, thank you. Hello, everyone. So here are 3 angiograms, and I'm going to show you the clinical details, and we'll come back to these cases at the end. But I wanted to begin by showing you a couple cases where you're going to look at them and say, I don't know why these patients have these symptoms. Why does the one person have angina? Why does the other person have dyspnea? It's not obvious when you just look at the coronary vessels themselves. Instead, we need to look into what's happening to blood flow to the myocardium. So let's start off by going through these cases, and the first one actually ends up being the most common one if you just look at the entire population. So this is a woman who has severe angina with during her diprotomol stress infusion. You can see that she had the recent angiogram that I showed you. She has some left ventricular hypertrophy. She's obese, normal ejection fraction, and you can see that her coronary flow reserve is intact. We measured it by PET. The reason that she has these symptoms is because of blood flow to the innermost layer of the heart. So what I'm showing you over here on the right-hand side are the cross-sectional images at rest and then at stress. And I've taken the innermost border, that is the subendocardial border at rest, and I've copied it over to stress. And you can see during stress that basically around the entire 360-degree view, that innermost layer is hypoperfused compared to what it used to be at rest. And there's ways that you can quantify this, but this subendocardial ischemia in her probably accounts for somewhere up to a quarter of the left ventricle. So that's where her symptoms are coming from. I'd like to go to an older concept to help think about this trade-off between how much blood supply comes into the myocardium and what the oxygen requirements or demand are of it. And a simple way of thinking about this is to look at the area under the left ventricular curve during systole, that amount of squeeze, that force that has to be generated, that is proportional to how much blood flow the myocardium requires. And then during diastole, the difference between the coronary pressure curve and the left ventricular curve is a measure of how much diastolic supply goes back to the myocardium. So when these two come out of sync with each other, that's when patients have symptoms. And what's been well understood for a long time is that the first and most sensitive part of the heart that becomes affected when this balance goes out of sync is the innermost layer, the subendocardium. So take a look over here at this lateral wall. You can see that this is an artificial stenosis created in the circumflex. And yes, perfusion is lower in the circumflex, but look at what happens across the wall. It's reduced a little bit in the subepicardium, but it really disappears in the subendocardium. And this is actually really well reflected in a large number of pathologies that were investigated. When this supply-demand ratio goes out of sync, what happens first is that the subendocardium falls faster than the subepicardium, and that's what happens here with this red line. So let's think about ways that we can then shift this supply and demand balance back into favor for patients. And what I will do over the next few slides is show a couple examples of how this can happen. But basically, the higher the systolic work that has to be generated by the ventricle, the greater the demand. And the smaller that area during diastolic supply, that is when you're going to then shift out of balance. So taking those concepts and coming back to this woman that we had, the reason that she has subendocardial ischemia is because she has left ventricular hypertrophy. You can almost see the tortuosity in her coronary arteries. Her blood pressure was not well controlled. And because the LV is thick, that then increases the amount of demand. And in her particular case, she's also obese, and that probably causes some degree of diastolic dysfunction. And so her LV filling pressures are higher than normal. And so particularly when she has tachycardia and the diastolic perfusion period decreases, that's what drives it. And so the way to help her out is to have weight loss and to work on controlling her blood pressure. Let's think about a couple other scenarios. So this is a woman who developed moderate angina as well as EKG changes during vasodilator stress. You can see that she has coronary disease, but her stents are patent. And the mechanism for her is the uncommon situation of intrinsic microvascular dysfunction. She simply cannot vasodilate. Her coronary flow reserve is about 1.8. We test caffeine in everyone who comes into our lab, so it's not as if this is a false negative or something like that. And you can see on the cross-sectional images that the subendocardium is in the same place at rest as at stress. In other words, there is no subendocardial ischemia. Flow is just globally down across the entire wall of the left ventricle due to primary microvascular dysfunction. This is a different patient. She came to me because she had frequent palpitations, and when I did her PET scan, there was no coronary calcium, and you can see really fantastic blood flow at rest and at stress. There's no subendocardial hypoperfusion. Her coronary flow reserve is intact. So she has normal flow everywhere in her heart. Why then does she have 7 out of 10 angina? And look at the EKG changes, right? You might say, well, maybe her symptoms are due to something else, but you can't fake the EKG. So what happens in these kind of patients is, I think if you didn't have the PET data, you would be tempted to say that there's ischemia here. But there's not, because we measured flow everywhere. She has great flow across the entire wall of the LV. I think what happens in patients like this is probably a mechanical stretch function. When you have hyperemia, there's an increased blood volume in the LV that causes a stretch. And just like stretch on your skin or in other places of your body can cause tactile sensations, I think that's probably what happens in these patients, that it can actually trigger pain fibers. And the distortion of the myocardium then from hyperemia in some patients causes repolarization abnormalities. But you can't say that someone like this has ischemia, but the only way to understand that is to measure blood flow everywhere. This is the last case, a 65-year-old woman who has dyspnea. You can see her angiogram, and during vasodilator stress, she had significant ST segment changes. And in her case, again, if we come up to the cross-sectional images, there's really circumferential hypoperfusion in the inner subendocardium. In her particular case, this is a secondary phenomena due to hypertrophic cardiomyopathy. She underwent a cardiac MRI scan. You can see her thickened interventricular septum. And so the reason that she has subendocardial hypoperfusion is because of an intrinsic myocardial problem, hypertrophic cardiomyopathy. So to come back to these angiograms, you can't tell what's going on just by looking at the angiograms. I think that's one of the key points for no-stenosis angina. You know, if I could take an angiogram and match it up with the mechanism on the right-hand side, it's all guesswork until you've actually gone in and measured blood flow across these areas. Subendocardial ischemia, if you think about these kind of 4 patients I've shown you, when we look at our patient population, it turns out that maybe 3 out of 4 patients, it's really a subendocardial mechanism that produces these kind of symptoms in patients. And so to summarize, if I just could get you to kind of remember a couple key points I said. The first is that the subendocardium is uniquely sensitive to pathology in the heart for all the reasons that I mentioned. It's something that you really need, I think, imaging tools to understand, things like cardiac PET or MRI. And we've talked about ways that you can shift the supply-demand balance in order to help patients' angina. Thank you.
Thank you very much, Niels. It was a very interesting session. I have a couple of questions. The first question is to Dr. Ando. Oh, sorry. Oh, sorry,
No problem.
Dr. Kubo. I apologize. I greatly apologize.
Yes.
Please go ahead.
Yeah, sure. Don't forget the imaging. Okay. So today I would like to talk about the MINOCA, MI, non-obstructive coronary artery disease. I would like to share my case, 70 years old female. She had a palpitation and just discomfort during daytime exercise. Past medical history included hypertension, and she was a past smoker. Blood testing showed troponin and CKMB increase. And ECG demonstrated elevation and a T-wave invasion in precaudal read. And angiography, emergency angiography demonstrated there is no significant stenosis in RCA, LCX, and LAD. There is no stenosis. And ventriculography demonstrated apical ballooning and suggesting Takotsubo disease. And we performed OCT imaging in LAD. There is no thrombus, there is no rupture, no erosion, no calcified nodule, no scat. But we found intimal thickening and intimal bump in mid-LAD. Previously, we reported OCT images of coronary spasm. Intimal bump and a tunica media thickening is a morphological characteristics of coronary artery spasm that can be identified using OCTs. So in this case, OCT suggested the presence of vasospasm. Subsequently, we measured physiological testing at CFR 3.1 normal range, a little bit reduced, but IMR 15 normal range. Day 3, we performed the BMI-PP metabolic scanning and the thermal perfusion scanning. So shown in this panel, the defect was observed compatible with the LAD supply area, suggesting coronary events rather than the Takotsubo disease or cardiomyopathy or myocarditis. Day 7, echocardiography demonstrated the apical ballooning hypokinesis was improved. So day 7, we performed Lee coronary angiography testing, and we performed the vasospasm provocation test. Acetylcholine injection into the LAD significantly induced the vasospasm in LAD, inconsistent with the OCT detected intimal bumping. So we concluded that this case might be MINOCA due to cardiovascular spasm. This slide shows the flow of the diagnosis. This patient had a MINOCA. OCT demonstrated intimal bumping suggesting spasm. Physiology testing excluded the microvascular disease. LBG demonstrated apical ballooning suggesting Takotsubo disease. But the BMI-PP and Atrium showed the defects in LAD perfusion area, suggesting coronary artery disease rather than Takotsubo disease, myocarditis, and cardiomyopathy. So we performed the acetylcholine provocation test and induced the spasm. So we concluded the vasospasm. As shown in this case, the diagnosis is MINOCA. A combination of physiology and imaging is very important. Especially in this case, OCT plays a very important role to arrive the accurate diagnosis. I would like to share some cases of MINOCA. This case, 77 years old male with non-STEMI. Angiography demonstrated mild stenosis in proximal RCA, some irregularity. And OCT clearly demonstrated multiple plaque rupture in the region. This is a lesion and proximal LD, mild stenosis. OCT demonstrated a lesion. And this is a calcified nodule. 68 years old male with non-STEMI. Angiography, there is no stenosis, but OCT demonstrated calcified plate and a calcified nodule protrusion. And this is a 44 years old woman present with non-STEMI. Angiography, there is no significant stenosis in RCA, but OCT clearly detected spontaneous coronary artery dissection and intramural hematoma. And in this case, he's a 64 years old man. There is no significant stenosis, but OCT demonstrated intraproximal hemorrhage and minor lumps suggesting a lesion. And we performed the provocation test. There is a spasm and a mid-LD. So, INOCA, myocardial infarction with non-obstructive coronary artery disease, is a walking diagnosis. So don't stop diagnosis at INOCA. So in the accurate diagnosis, OCT plays an important role to diagnose different etiology, different mechanisms, including rupture, lesion, calcified nodule, SCAD, embolization, and spasm. And OCT diagnosis of the mechanism of INOCA allows us a mechanism-targeted treatment. So, for example, rupture allows DAPT, statins, ACI, ARB. Spasm, calcium blocker, thrombosis, anticoagulant. SCAD, beta blocker, or PCI to the entry. So, conclusion, ladies and gentlemen. So OCT is useful in identifying the cause of INOCA and in guiding mechanism target treatment. Thank you for your attention.
Well, thank you very much. It's a fantastic session, as Nico was starting to say before. We have covered so many interesting topics. Well, let's start by taking some comments, please.
Thank you for great talk. I'd like to have a comment for the spasm. The first talk, I'm really surprised that we need to pay attention to the focal spasm in myocardial bridge patient. I published 2 papers before, quite a long time ago, in AJC and Heart as well. At the time, I investigated that story using the acetylcholine challenging study. Did quite amazing, very severe focal spasm in the myocardial bridge patient. Also, at that paper, the patient, the nodal blocking calcium channel blocker like the diltiazem might be better as compared to beta blocker nitrate alone. That is my suggestion. The one more question is, I'm wondering what the protocol can be better, the acetylcholine versus the organobin. The Japan group, they usually prefer the acetylcholine rather than the other one. But the other countries has the regulation, the issue, therefore they cannot use the organobin, actually the Korean as well. Do you have any comment on that?
I mean, if I may, because you mentioned the topic of myocardial bridges. You know, I think it was in 2002 that we proposed, we investigated myocardial bridges using dobutamine and using diastolic fractional flow reserve. And we found that, yes, in some patients, actually, you have an obstructive component of a dynamic component of myocardial bridge that may explain ischemia. But I think that since then, we have seen also that it's quite frequent that these segments have abnormal vasomotion that you can trigger spasm. Now, I think that this is something that will need clarification because, as you know, if myocardial breach is an obstructive problem, the main drug that you will use will be a beta blocker to decrease inotropism. But of course, I mean, that will not address spasm and could make it even worse. So nowadays we try first, we always do acetylcholine testing in these patients, and sometimes we also look to the obstructive aspect of it, and we try to tailor as much as possible the mechanism. Regarding the acetylcholine, I think that can be answered by another colleagues, but my observation I can make any time that someone says that it is not an indicated in the country, I ask if adenosine is indicated in the country for FFR. Because in my country, it is not indicated. In the States, it's not indicated. And people are using adenosine for FFR, while it is not indicated in the same way that acetylcholine is not indicated for spasm. So that is my first provocative comments.
So, Javier, I think that one of the things that I think we should aim in this type of sessions is to facilitate the assessment of everything that has been discussed. And one of the things that I like to say is that how all this fits in the workflow. And one of the things that you mentioned in the introductory talk was that if a patient comes to the lab, lie on the table, and there are normal coronaries, that is an indication that you should go forward. I think that the first step is extremely easy. Dr. Ando showed how to measure CFR and IMR with bolus tremodilution. You said that in your study it took 15 minutes. In my lab, we use intracoronary papaverine. It takes 2 minutes to do the complete assessment of CFR and IMR, and then going to acetylcholine testing, which we do routinely. My question is the following. Based on the presentations, there is a question about timing. Now, we in ALS, we schedule the patients for acetylcholine testing. We don't do ad hoc, okay? Now, I have seen labs where the acetylcholine is prepared inside the cath lab, and I wonder whether that approach of having the acetylcholine ready and just go forward will be more practical. So that's one point that I would like to hear your thoughts on. And the second question, maybe for Dr. Kubo, is in the context of ACS, when in your experience do you think it's safe to go from the acute event where you do OCT because you have that wall motion normality that was very elegant to demonstrate, and when is safe to do then the acetylcholine testing? So kind of two questions, both based on timing, one in more stable and one in stable. Javier, I don't know, what do you do in Madrid? Do you do ad hoc acetylcholine, or you plan that?
We make the mixture, we make the solution in the cath lab, yes. Now, regarding MINOCA, and that will be my question, my problem with MINOCA and acetylcholine testing is that I don't know if I'm seeing the chicken or the egg. Because if you have, if there is a cause of myocardial insult, of ischemia that has damage, so to speak, or has caused a trauma in the myocardium, I don't know if the abnormal vasoreactivity of that segment is due to the fact that it has been stunned myocardium. You understand what I mean? So to me, it's very difficult sometimes to establish a relationship or say, okay, it was a spasm what caused the damage. No, perhaps there was a damage caused by something else, for example, myocarditis. And of course, you have a spasm because in the context of myocarditis, the whole vascular system is hyperreactive. So that's my comment about in the context of acute coronary syndromes of using acetylcholine testing. But I would like to hear from the colleagues, of course.
So in my practice, I perform the acetylcholine injections ad hoc because, especially in ACS patients, it is very difficult for a patient with second time testing. So if patients have MINOCA, we proceed to the acetylcholine injection in ad hoc. It is my practice.
I usually perform the provocation test of acetylcholine 1 or 2 weeks later after their ACS, because in ACS patient, even in the mechanism of atherosclerotic disease, the lesion and vessel is vulnerable at the time of ACS. So false positive might be increased due to the, according to the provocation test. So first, I would like to stabilize the patient, stabilize the lesion, stabilize the vessels, and then we perform the provocation test. Thank you.
Ik, do you have any comments?
No, I have a question to Niels Johnson. At our institution, PET-CT is rapidly replacing MIBI. Do we need to change the intravascular provocative or test strategy?
I think if you're able to quantify flow by PET, there are very few people then that you need to take to the lab and measure flow in because you've already done it. And I think that it actually offers two advantages. The first is that you're able to see flow across the entire left ventricle, so you don't need to just, often in these sessions people will just interrogate one vessel or maybe two, but just because of the imaging technique, you're able to understand flow across the entire ventricle. And then the second part of it, which I don't honestly know of a way for us to get in the cath lab, is you're able to understand what happens to blood flow to the subendocardium. And so that, often on SPECT, you'll have this notion of a TID, a transient ischemic dilatation. It's not the right name. The ventricle doesn't dilate, and it is transient, though. But that shelling out, that subendocardial hyperperfusion, is something then that you can uniquely see that way and ends up being the most common mechanism. So I think if you're it's fantastic that you're getting rid of SPECT. I think I think that's the wave of the future, and those are the kind of pieces of data you'll be able to use to make diagnoses without having to go into the lab and make assessments.
How about microvascular spasm?
Yeah, so you can get a lot of people's coronaries to do what you just saw up on the screen up here. I think very few of that happens in daily life in patients, although, the kind of cases that have been presented here, I think, are the kind of ones where that actually is probably clinically relevant and not just an angiographic effect of giving lots of acetylcholine to people.
So in my practice, PET-CT is the first step.
No,
I stopped doing MIBI, and when I still have suspicion for microvascular spasm, isn't that a subgroup that you want to bring to the cath lab?
I think that would be a small subgroup to focus on. Sometimes in PET, what people have done in the past also is cold pressor testing as another stimulus to try to induce spasm in patients. And we've done a few of those over the years. You can put people's hands in cold buckets of ice and things like that, again, to try to heighten sympathetic tone and bring out spasm in some of them as another alternative for that kind of thing.
I have to say that when you think about which test it's most important in these patients, and I think in our practice, the spasm testing, I think, is one of the most important because one, you have an action linked to that, a medication that makes the patient feel better after the procedure, and the prevalence is not small. Both, the Japanese data, the Dutch data, the Belgian data all point out at a prevalence of about 40 to 60% spasm, so that's a lot. And I think those patients they feel better after you put the correct therapy. So I think this is something that should be encouraged, especially in these patients with ANOCA or MINOCA.
So for Dr. Ahn, that you presented very, very interesting, concept of pressure-derived coronary flow reserve. Are you currently making progress in the investigation in this particular topic? Do you think that that's a how do you think that, do you think that there will be a clinical application, systematic application of pressure-derived coronary flow reserve?
Yeah. Actually, this is not the accurate measurement of coronary flow, just the pressure. We assume the flow reserve based on the pressure measurement. In addition, when we measure the coronary pressure, we have to consider the hydrostatic pressure. So in this formula, we don't consider the hydrostatic pressure measurement. But if we consider the hydrostatic pressure, then coronary pressure reserve would be very similar to the coronary flow reserve. So we can only measure on the screen of FFR measurement. We can directly guess the patient coronary flow reserve, I think.
And of course, I mean, this coronary flow reserve in cases where you have a stenosis, of course. If you do not have an stenosis, you cannot calculate it, of course.
But in this case, it is the one advantage of pressure measurement because by the formula, the FFR FFR 1 minus FFR divided by 1 minus PDPA. So on the numerator divided by by the formula, epicardial coronary artery stenosis already adjusted. So regardless of FFR value, the mean, the CPR is consistent. Median CPR value is around 2.7 something. So I think this kind of measurement, may have a very little impact of epicardial coronary artery stenosis.
Fantastic, very good.
Yes, I would like to make two questions. The first one is many of the ladies with left ventricular hypertrophy are just claiming of discomfort, chest discomfort, maybe angina. What do you recommend for testing them, and if there is a specific study, because there's a population of about 40% of these patients that can have vasomotion problems, you know? What do we do with them? And and the second question is the INOCA patients. After I heard Dr. Kubo, he recommends for all these patients, if you don't find nothing in coronary radiography, go straight to pneumatics, OCT or another one.
You want to answer the first question, or
Maybe somebody else?
who would like to answer the first question, that is, what happens in a woman that has left ventricular hypertrophy? What is next? Yeah. I mean, obviously, I will start part of the answer, but I think that we know that left ventricular hypertension is obviously something that is strongly linked to structural remodeling of the microcirculation. But I guess that the second thing, one of the great things that we have of making a comprehensive diagnosis is that because this is a very heterogeneous response, you can really clarify if that is the cause of, say, abnormal hemodynamics in the coronary microcirculation, or if the patient, on top of that, or apart from that, has vasomotor disorders. What would you say on that, Carlos?
So I think that's a very good question, and it goes again to the practicalities of testing of the microcirculation. If you have this type of patients, and I think the first thing you need to do is to measure the left ventricular and diastolic pressure. I think this is an integral part of all these measurements, because if you have high LVDP, you basically have a secondary mechanism that is compressing the microcirculation. So that is key. And how to interpret measurements in the context of high LVDP, that's a very good question. I think nobody knows. But this is something that if you go blindly to the coronaries and then you have find high resistance, you will say, that's coronary microvascular disease. No, it's not. It's a secondary cause that is basically causing the lack of vasodilation. So I think, we are, of course, focusing on the microcirculation here, but I really like the approach of Dr. Johnson, because there is a patient, and the patient, you have to be looking in the context of how is the left ventricle, how is the left ventricular pressure, and these things needs to be amalgamated to make the correct diagnosis. So that will be my approach in your case.
And to come back to that, for left ventricular hypertrophy, you can have intact epicardial inflow, but you can still have subendocardial hypoperfusion. So you can go into the epicardial arteries and still measure, CFRs of 3, MRRs of 3, but yet the patient can still have chest pain when ambulating because tachycardia, high LV filling pressures, and uncontrolled hypertension lead to subendocardial hypoperfusion.
So, Niels, now that you are there, your graphics were very nice of hemodynamics, and you were saying that actually the systolic part of it explains very nicely the oxygen consumption, and then you have the diastolic part of it saying that you have. But just clarify something, if a patient has diastolic dysfunction, I think that's something that we know is that diastole is not a relaxing factor without oxygen consumption. It is more like a zip that you have to pull up and down, so you consume actually a lot of oxygen in the generation of diastole. That is what we learn in the medical school. In a patient that has diastolic dysfunction, does the heart consume also more oxygen during diastole?
So I guess you're right. That ratio that I'm talking about that's been proposed is an imperfect measurement of myocardial oxygen consumption for all of the reasons that you mentioned. I think that if we're talking maybe about this patient who had, LV hypertrophy and hypertension, probably both sides are out. You've got increased systolic myocardial oxygen demand, and then during diastole, LV filling pressures are higher, and so you've reduced the amount of supply that gets delivered as well. So both things can go out for the same reason in patients who have LV hypertrophy.
I think it is very difficult to unravel that because diastolic dysfunction can be the cause of oxygen lack of ischemia, but ischemia can be the cause of diastolic dysfunction too, very easily.
Yep.
It's very difficult to unravel that.
Please.
Major difficulties in evaluation of INOCA and MINOCA need of a lot of time and cost. So stepwise approach might be very, very important. So we should consider the incidence of etiology. Sometimes some guidelines suggest microvascular function first. Some guidelines suggest variant angina evaluation first. So I'd like to ask to Ando and Kubo. So do you think which one is first should be provocation test or microvascular function test?
Yeah, it's a very good question, but in my practice, I should do the most possible mechanism should be evaluated first. In Japan, many patients has vasospastic angina. Most patients, vasospastic evaluation is first. But second, on the second evaluations, microvascular dysfunctions is little bit difficult because affected by first testing. So in my presentation, I show the misdiagnosis, like a structural microvascular dysfunction, but actually that was caused by the acetylcholine injections. So this kind of interpretation is very important.
That's, I will be interested in knowing also other opinion, Dr. Kubo, but we actually answered that question in the 8-angio study. In the 8-angio study, the clinical cardiologist saw the angiogram, had a look to the medical records, and then he had the option of saying, I think that this patient has INOCA. And then he had to put what type of INOCA, that was vasomotor or microvascular, and what type of treatment. Now, when we had a look to the response, the clinical cardiologist was wrong in 80% of patients. So that means that the proposal of saying, oh, you go and first try it medically, means that in 80% of the cases, the strategy of the clinical cardiologist will be wrong. So I believe that is why, 8-angio was published in January 2025 after DAC guidelines, but I invite you to have a look in that. I think that provides a very clear proof that just with the pattern of angina, medical records, and what you see in the angiogram, a clinical cardiologist cannot really say if it is a vasomotor, if there is INOCA, if it is vasomotor, or if it is a structural. That's what we learned from the study. I don't know if, Dr. Kubo, do you have any additional comments?
Yes, I completely agree with you. Yes.
If I can ask a question to Dr. Kubo. So MINOCA patient, you do a cardiac MR and OCT. And oftentimes, in my experience, we discovered rupture plaque, but very small, without real evidence of recent thrombus. So the positive troponin, is it really from the small plaque rupture, or is it, incidental finding?
Mm-hmm. So in MINOCA, the frequency of vasospasm is most often seen. Yes. And spasm-induced rupture is sometimes observed. And if lumen is widely opened, we can release it. But there is a luminal stenosis, we perform the PCI in that region.
Okay, ladies and gentlemen, I think that we had an excellent session. I would like to thank the audience in the first place, but also the speakers and the panel and my co-chairman. And I hope you will all have a very nice evening. Thank you very much.